All right, well, good morning. My name is Bill Nicotra. I'm the MSL and perfusionist for Essential Pharmaceuticals. I want to welcome everybody. It's so great to be here live and online with all of our friends and colleagues. It's great to see everyone today. So I wanted to say a big thank you to Taylor Kroll, who helped put this breakfast on. I think she did an amazing job, and breakfast was fantastic today. Wanted to talk a little bit about Essential Pharmaceuticals. Many of you may not know who we are. We're the largest distributor of custodial HTK in the United States. The company was founded on guiding principles such as highest quality product, the highest standard of excellence, trust, and a patient-first mentality. We have 24-hour technical support. Many of you may not know that. So if you have real-time technical questions in the field, we have 4 perfusionists on staff ready to answer any questions that you may have about custodial. And then we have a terrific customer service support team as well that we utilize. So without further ado, I'm going to start off today's talk. I'm going to go over some new and exciting things that are happening in custodial, in the world of custodial. There are new protocols. For years, we've discussed only one standard protocol, and many of you are very familiar with that protocol. I'm going to go over that protocol, but there are new things happening, and we're very excited to share with you what's happening in myocardial protection utilizing custodial HTK. So for years, this was the gold standard for cross-clamp times of greater than 60 minutes expected time. You would give the standard dose of custodial HTK, and it has been the gold standard for years in the industry, utilized worldwide this way. You've heard me talk about this protocol, but I will go over it briefly. Obviously, custodial has to be refrigerated, so it's stored refrigerated, but it has a 1-year shelf life. So you hardly ever waste custodial cardioplegia. And then you can use any standard delivery system. So whatever you're currently using, you can still use when you use custodial HTK. So there's no upfront capital cost for you to start using custodial. And then you deliver custodial in the beginning, much like every other cardioplegia technique. You generate enough pressure to close the aortic valve, and when you start to get arrest, that's when it changes. As soon as you start to see arrest, then you back off your flow rate to about 80 to 100 millimeters of mercury, and you'll likely see that you're delivering it much like retrograde cardioplegia at that typical rate. And you give it for the pediatric dose is 20 mils per kilo, and I recommend that if you have patients that are less than 60 kilos, utilizing this technique to reduce hemodilution. So for up to a maximum of 2 liters, and then if you need to redose after 2 hours, then you use half the loading dose, whatever that was. So, and I just went over this briefly, that until you get arrest is when you back off. But the important thing to note here, and I have it bolded, is that time is more important in the delivery of custodial HTK than the actual total volume, because you need to make sure that you reduce that sodium level enough to reduce any possibility of any action potential to exist. And then this is common sense, but make sure that the heart's not distended so that you get really nice, even distribution of custodial to provide that 2 hours of protection. And then, as we just said, after about 90 minutes to 120 minutes, that's when you typically consider giving another dose of custodial HTK. And whatever that redosing volume is, it will reset the clock to another 2 hours. So you'll be provided, if a redose is necessary, with 4 hours of protection with just 2 doses of custodial HTK in this particular protocol. And that's really advantageous in the single dose techniques for surgeons to have just uninterrupted repair time and not worry about it. And if you're using this higher dose protocol, then you may need to hemoconcentrate if you can't scavenge the HTK into like a cell saver or a throwaway sucker. And this protocol is listed on perfusion.com. So if you want to see a copy of this, you can go to the website and see that. Some of the benefits that I noticed when I utilized Custodial at Temple University, the low viscosity allows for not only rapid arrest, but cooling the myocardium, probably colder than I'd ever seen a heart get in my 36 years of perfusion. The reduced potassium is advantageous. So if you've got patients that are predisposed to AKI, you don't have that high potassium load because there's just hardly any potassium in custodial HTK. So the kidneys aren't going to take that high hit. And then this is what separates custodial from every other cardioplegia technique utilized in the world. It has histidine, and we know that histidine is a powerful amino acid buffer, and it's unparalleled in buffering the pH. And then for this, we had one recognized protocol for years, so we had the same expected results every time. And there's no compounding with custodial HTK. So in an emergency, you pull it from the refrigerator, hang it, and you were ready to go. You don't have to worry about anything. And then retrograde's often unnecessary in typical AVR, MVR type cases, unless you're using it for CABG use, then I would recommend using retrograde. And there's a cold agglutinin protocol. So if you have a rare occasion that you have a patient that has this, you can actually cool the heart and protect the heart utilizing custodial HTK. So that was the gold standard and the high dose. But here's what's new. We have other options available for you for different types of cases. Dr. Gunaydin, you'll see him later on today. He will discuss a protocol that he developed called the low-dose protocol. And he'll use this low-dose protocol for cases such as quick AVR or MVR with a cross-clamp time of expected less than 60 minutes. And basically, the delivery will be much the same as the high dose. You'll give it exactly the same way. The only difference is that you're only giving a maximum of 1 liter for the 60 minutes of ischemic time. And if you're using this for CABG patients and you need to use retrograde, then 2/3 of that total volume would be antegrade, and then the last third would be retrograde. And if you needed to redose, if you thought it was going to be less than 60 and things happened and you needed to redose, then you would just repeat this induction protocol all over again, and it will afford you another 60 minutes of protection time. So why did we look at low-dose protocols? What are the advantages? Well, as we know, single-dose techniques are very popular and talked about probably ad nauseum in a lot of the conferences, but data will show that it has better long-term outcomes for single-dose techniques in less than 60 minutes, and you'll see evidence of that today. And then, obviously, reduced hemodilution. So now if you have a case that's less than 60 minutes, you're not gonna have to go with that high dose protocol with the 2 liters. And then hyponatremia, which often is evident with the higher dose protocol, it may not be evident. You may not even notice any hyponatremia. And it could reduce the need for hemofiltration, a much talked about topic today. But you do have that high propensity for redosing, and if you've seen any of Dr. Gunaydin's previous work, you'll know that redosing is not something that is without risk and without reduced outcomes. So then, on top of that low-dose protocol that you just saw, that we now have modified custodial. And so modified custodial will be essentially using it just like the original Del Nido formulary at a 1-to-4 ratio. So you'll mix 1 part blood with 4 parts custodial, HTK, and you will give it exactly the same way that you would the low-dose protocol absent the blood. And why consider using modified? Well, the first to me is a no-brainer. Now we have an apples-to-apples comparison to the original Del Nido formulary that's being used in the adult population. And so if you want to do prospective work and take a look at what your institution is doing, you have an option to go and do a direct comparison. So you're using 1-to-4 versus 1-to-4 in the same ischemic times that are widely reported. But the second part is cabbage use. So I've been with Custodial for about 5 years, and a common concern that I heard in the field was that it's probably not great for cabbage use because if you're using 100% crystalloid, it has sometimes the effect of bleaching out the heart, and it makes it difficult to trace the targets, so the surgeon has a difficult time marking the targets and seeing where he needs to go. Well, now that you're adding 1 part blood to this, now it makes the coronaries just show up so much better, and the surgeons have easy access to the repair. And then all the other reasons that we had mentioned in the previous low-dose protocol. So that's what's happening in Custodial now that's new. I'm going to be here all week. I will be happy to answer technical questions when it comes to the delivery aspect of the new protocols that you're about to hear today. But I have the absolute distinct pleasure of bringing our actual keynote speaker to the podium today. He's Dr. Gunaydin. He's a friend and colleague to everyone here in this room. Everyone is very well aware of who he is. He's a professor and cardiac surgeon at the largest cardiac center in Turkey, in Ankara-Turkey. He's a world leader in looking at long-term outcomes of all cardioplegia modalities, not just custodial. He's considered the world leader. He has so many publications to that effect. Some of his other passions include minimally invasive techniques and blood conservation techniques. So without further ado, I would like to welcome Dr. Serdar Gunaydin.
Thank you. Good morning, and thank you very much for this introduction. It's almost my pleasure to be here. Last time I was here in 2019, so it's been, unfortunately, 3 years now, right? So we have very hard time because of the virus. And finally, even in our country, the mask limitations is over now, so we don't need to use masks in our daily life. I work in one of the largest centers in Europe. We have about 5 surgeons working in this hospital. We have 12 operating rooms doing about 3,000 cases even in the COVID era. So we do every type of surgery, including transplantation, ECMO, and pediatric, and everything. So we have options to try different modalities, different surgeries. I've been interested in doing especially perfusion-related technology research for a long time. I also have a PhD in bioengineering, so I also teach in bioengineering schools in Turkey, England, and Germany. So when you check for the literature and you write down only simply cardioplegia, you can have hundreds of papers. And most of them, of course, are related to blood cardioplegia because it's one of the oldest ones. And also when you check for the research, you see that there are many papers, starting from, of course, like before 2000, focused on blood cardioplegia because single-dose techniques have become popular very recently, let's say 7, 8 years, because we used to use Del-Nido cardioplegia in pediatric research. And I'm the first one to use Del-Nido in Turkey in adult case. Everybody was looking at me like a crazy guy, giving only one shot for a cabbage case up to 5 vessel. And this was the start. Now it's become one of the most popular formulas in Turkey. So as you know, Del-Nido is a very simple simple composition, but the only tricky point is to manage lidocaine level. It's becoming much more important, especially in the repeat doses. So in our research, we always focused on to manage the lidocaine dose to bring it half, and then 1/4, sometimes the same dose in the repeat dose. So we tried many different things to find the correct one in the second dose. And the second point we always focused on was how long is the safest ischemic time? So you give like 1 liter for 1 hour, 1 liter for 2 hours, 1 liter for 1.5 hours, what? So we did a lot of research, and I will mention them later. So, of course, it's originally designed for pediatric surgery, and there are now maybe more than 300 different solutions. All of them are calling themselves their Del-Nido, but most of them are not Del-Nido indeed. So HTK is a very old cardioplegic solution, especially used for heart protection and in the transplantation era, designed by German doctor, Dr. Köhler. And it depends on 3 different amino acids. Histidine is one of the most important point in this composition because it controls the buffering system. So, you know, Custodial may be expensive solution because of histidine, because it's the most expensive unit in this composition, and it's very hard to get indeed. So ketoglutarate brings the energy in the ischemic period, and tryptophan is very much like lidocaine, stabilizes the membrane. So when you compare them in the pediatric way, within the literature, of course, they both work very well, and also in transplantation. But when it comes to the adult cardiac surgery, it's different. In the early phase, nearly all the papers are showing that they are very much same in the early clinical outcomes, but very few papers about the long-term outcomes. So we, again, now started to see some meta-analysis because there are many publications in the recent 5 years, let's say. And even all of those meta-analysis, we see in the early period, within, let's say, 5 days, 7 days in the hospital, whatever you give, like blood, Del-Nido, Custodial, the early results are very much same, especially in normal risk patients. We are not speaking about the high-risk patients. So this is the composition of the current literature, early and late. So, and also in Europe, the most popular one, again, this is another paper to check one, what are you using in your cardiac surgery? Most popular one is, again, blood cardioplegia, and in the US, this is the paper of my dearest friend, Alfred Stemmers. As you can see, it's 4-to-1, is popular in CABG in the US, and the Custodial is only #1 in urgent cases because it's ready to use only one formula. And this is the quote from one of our very famous philosopher, Rumi from Turkey, and says, now we have to say something new. That's how we started our own research, and we started with the first question, which single-dose technique is good for which type of surgery? And we started from the lab. We have a very good lab backup in our country, so we just work on cell cultures. So we have myocardial cell cultures. We put different cardioplegic solutions on them, and we check what will happen. So this is the direct view, and we use 3 different cell lines, one representing neonatal cells like pediatric surgery, one representing adult surgery like adult human endothelium, and myocardium itself. So this is the setup of the experiment. Any laser pointer here? This one? Yeah, but very, yeah, okay. So these are the cell lines. like myocardium, adult and pediatric, and these are the solutions: St. Thomas, blood, HDK, Dalnido. And the formula is very much same with the operation. And we did different types of testing for toxicity, because toxicity is important, especially in Dalnido, by the lidocaine dose, as I mentioned before. And of course, we also would use some microscopic evaluation at the end. So these are the results. For fibromyoblasts, the myocardium itself, the single dose techniques are good in the long term. In the early phase, is very much the same with the current literature. There are not any differences. In adult cardiac cells, in the early phase, again, not any much difference, but in the long term, HDK becomes prominent. And this is neonatal cells, like representing pediatric cardiac surgery. Both Dalnido and HDK are much better than the control groups in the long term. And this is the microscopic evaluation. When you see the green cells, they are viable, and red cells are not viable. So control is the best solution we use. So you can see 6 hours, 24 hours, 48 hours. And again, like single dose St. Thomas or blood are failing in the long term. And this is the adult cardiac surgery. HDK is very good going on. Dalnido is becoming much less prominent in the long term. And this is for pediatric. Both of them work well. And there's no toxicity in any of this if you use only one single dose. So as a conclusion of this one, we concluded that, okay, in the lab, Dalnido and HDK works perfect on pediatric cells, but in adult cells, in the long term, HDK becomes much more prominent and significantly different than the others. And then brings the other question: how about the long-term protection? Okay, we do the operation, we finish, we discharge them in 5 days, 7 days, whatever. So what happens next? So then we also published this paper in Asian Annals last year. In this case, we just compared 3 different groups: Dalnido, HDK, and blood cardioplegia, with 100 patients in each group. This time, we also tried to demonstrate the endothelial glycocalyx degradation. It's a very new parameter showing us the earliest sign of disturbance of the myocardial cells. So this is the endothelium here, and this is the glycocalyx layer over endothelium. So if something happens, like overvolume, ischemia, acidosis, it's the first line that will break, degrade, and we can see the results in the blood. So it's the earliest marker of any potential damage. So for long-term follow-up, when we discharge the patient, we put on some kind of iPhone-like machine on them that records 24/7, like the ECG, blocks, bradycardia, AFib, and angina. So there is a button here. Whenever the patient feels uncomfortable, he or she presses the button, and then there's a message center that receives all the calls. So we follow up those patients 1 month in this way up. And the only difference in those patients was the choice of cardioplegia. And again, in the early period, before discharge, there was no significant difference in any of them. And in 1 month control, we started to see some differences. So this is much better here. So in 1 month control, you see that the Dalnido group, more incidence of tachycardia, more incidence of AFib, and more incidence of rehospitalization. So this also brings up the discussion on the cost. So in cost effectiveness, what do you measure? Inside the hospital, or all period of the patients including rehospitalization? So as a conclusion of this, we said that in the long term, Custodial is much more safer than any other single-dose techniques. And now we come for another question: hemodilution. Yes, hemodilution is a very important concern of any of the single-dose techniques, because you deliver like 2 liters in, let's say, 5-6 minutes, and it really causes hemodilution. So you need to do something to overcome those hemodilution. So in this sense, we again compared 4 different groups and about 300 patients in each one. So the primary endpoint was the transfusion rate, and the secondary endpoint was the hematocrit change. And this is, I can show you this one. Whenever we use any single dose, Dalnido or HDK, it doesn't matter, in CABG surgery, We routinely use retrograde cannulation and LA venting. And at the end of operation, if you use full dose, we always use hemoconcentration. So we need to do 3 additional procedures like LA venting, retrograde cannulation, and hemoconcentration at the end. If you do all of them, then there is no concern on hemodilution. As you can see, baseline, on pump, last dose, after ultrafiltration, ICU. So not significant differences in transfusion or hematocrit change. This was the conclusion of this study. And then comes the next question, redosing. It's much more complicated concern. So then you need to discuss the safest ischemic time, especially for Dalnido, because for HDK, we are okay. If you give 2 liters, you have at least 2 hours of protection in 85, 90% of the cases. But in Dalnido, it's not the case. So when we started using Dalnido for the first time, we were giving 1.5 liter for 90 minutes. It didn't work. So we give 1.5 liter for 1 hour. Yes, it really helps in the early phase. But if you need to give an additional dose, it's a complication. So at that time, like 6, 7 years ago, we started our minimally invasive program. And of course, in the beginning, we were not very much experienced, so the cross-clamp times were much longer. And we have many problems in redosing of those patients. So we also published this redosing in Innovations last year. So we compared this time Dalnido and HDK, 100 patients in each group, plus if you give redosing, we did some subgroups to understand the effects of redosing. So at this time, we check for the aquaporin levels. It's also a new prognostic evaluation technique. Aquaporins are the proteins in the myocardium to deal with the overvolume. So when the cell is faced with overvolume or hemodilution, the cell starts to produce aquaporin proteins to overcome. If the cell fails, then you can see less aquaporin. That means a less response to the overvolume. Again, in the early period, even in this minimally invasive patients, there is no difference. But this is the repeat dose. So in the repeat dose, the red ones are the significantly different ones. So AFib incidence were higher in the Dalnido group, block was higher, and ICU stay was longer in redosing. This is because of the lidocaine toxicity of the incidence of higher arrhythmia. And also, the aquaporin levels were much lower in the Dalnido group because of the lidocaine toxicity. The cell cannot respond to this second volume, and you can see it microscopically. When the picture is bright, that means the glycocalyx layer is degraded, and the glycocalyx is out of the cell, so you can die. So it's not good. So the bright picture here shows the endothelial glycocalyx degradation of Dalnido versus HDK here. And this is the aquaporin level, as I've told you. Cell produces some kind of proteins to deal with the overvolume. In Dalnido, you can see the cellular edema because of the failing of the producing enough molecules. This is the conclusion of this study, that we should say redosing is not preferred. We need to plan our surgery as much as excluding any redosing. But if we need redosing in Dalnido now, we reduce lidocaine dose 1/4 and to avoid any kind of problem. In HDK, we don't have any concerns in redosing. So temperature and pressure is also very important, which temperature you're giving and which pressure. So especially for HDK, we also work with Germans to show it on the intercellular level. You need at least 5 minutes to reach the adequate sodium levels to make the impact of the cardioplegia. If you are less, like 2-3 minutes, it doesn't work very well. So you need to adjust your pressure to give whole volume. Whenever you give 1 liter or 2, it doesn't matter, should be above 5 minutes. So even Germans are suggesting 7 minutes, but it's usually very long for a surgeon to wait that long. So as I've told you before, for CABG surgery, always retrograde, LA venting if you are using full dose. If you are using the lessened dose, I will talk later, you don't need any of this. So, and then we come to another question, as Bill mentioned before. Okay, giving full volume takes a lot of time. have some concerns on hemodilution, sodium levels, or whatever, especially in Dalnido for arrhythmia. Can we do something else to overcome? So like 75, 80 of our cases are having ischemic cross-clamp time less than 60 minutes, like CABG plus 2, CABG 3 vessel or whatever. So this time we just come with an idea to lessen the delivery dose to 1 liter and ask for 1 hour ischemic time. So we also published this in EACTS, presented in the EACTS meeting this year. So this time we compared again 3 different groups, Dalnido, HTK, and blood as a control. And again, in the early period, not any differences. And so we were successful giving only 1 liter for 1 hour in 92% of all cases of CABG times 3. So this is very practical. So if you use 1 liter, what we didn't use, we didn't have any concerns about hemodilution, no LA venting, no ultrafiltration, not any problem on sodium imbalance, and not any type of lidocaine toxicity in Dalnido. So 1 liter for 1 hour worked very well in CABG cases, especially up to 1 hour. And then we also use this for valve surgery, for simple single valve like AVR or mitral valve. So it really worked very well again. So we did this now, 89% of valve cases expected to have an ischemic time of 1 hour. It worked very well. And this is another paper we're going to present next month in the ISMICS meeting, in the minimally invasive cardiac surgery meeting. This time we use this diminished dose for minimally invasive aortic surgery. And again, it really worked very well. Although we have not many patients, about 80 patients in each group, it worked in 90% of the patients, so it was enough to give only 1 liter of HTK for 1 hour. And again, you can see the results here. They really worked very well. And the last innovation was to add some blood, because I really personally don't believe to have a blood composition to see the coronary vessel. I don't think that may make any changes in the surgical practice, but most of my colleagues insisted on having some blood portion in HTK to see the, some visibility of the coronary artery. And so we did this study. We did one for cardioplegic technique, and like we did it from the pump, like we did it for Dalnido, for example. And yes, the visibility was much okay, satisfactory for them. As I told you, personally, I don't see any difference, but they did. And in only like, it was 32 when I prepared this. Now we have more than 50 cases. And it really worked very well. Again, we're using CABG surgery, and we're using 1 liter, 1/4 for 60 minutes. And we have very, very good results. So as I've told, the histidine is the most important component of the solution. When we don't need to add blood theoretically, because the osmotic volume of the solution is okay. If you add blood, and we also measured the osmolarity, and it didn't make any significant difference. So adding blood is only preferable for the visibility of coronary artery surgery if the surgeon wants it to be that way. And the results are very much same, so even helped much better, less hemodilution results. So this modified technique is also being used in our clinic with some other surgeons. So as a result of all those studies, the single-dose techniques are currently becoming more and more popular, becoming used in every type of surgery, including pediatric, CABG, or valve, or minimally invasive. So we started using these techniques in the early days of minimally invasive experience, and now we come to a point that we do 85, 90% of all operations in minimally invasive techniques, including CABG times 3 in our hospital. And even in those patients, those single-dose techniques, the safest one, as I can confirm, when I feel myself comfortable, is using HTK. So why don't I use HTK for all cases? Because, of course, the financial problems in our country, because HTK is like 8 times more expensive than Dalnido, so we need to find a kind of equilibrium point to deal with those patients. So especially in high-risk cases with an ischemic time of, let's say, 2 hours, we certainly use HTK. In high-risk cases with expected cross-clamp time for 1 hour, yes. And in other cases, we discuss the situation of what to do in that case. So we are doing more and more research now, especially for redosing, because this question is still not completely answered. Okay, because we have much more incidence of redosing in when we are using 1 liter for 1 hour. So how do we proceed? Again, with HDK, additional one, or something else. So we are trying different compositions. So HDK is always safe. You can give overdose, even 2 liters, it doesn't make any problem. Sodium imbalance is never an issue for us, and we never correct any sodium imbalance because it becomes another problem in the long term. So we are trying the redosing. Maybe we'll present those data later. Thank you very much.